TVC Breakfast. Quite a very, very important conversation we're having in the studio. But yes, let's tell you this. Nigeria's medical tourism spending has crashed by 96% in the first half of 2025 compared to the same period in 2024. Now, according to the data from the Central Bank of Nigeria, CBN, the expenditure accumulated from $2.38 million in January-June 2024 to $0.09 million in the corresponding period of 2025. Now, this significant decline indicates a major shift towards domestic healthcare facilities, with Nigerians increasingly opting for local treatment options. Now, the CBN attributes this trend to investment in healthcare infrastructure, specialist training, and cutting-edge medical technology, which have expanded the range of complex procedures available within the country. Now, joining us in the studio to discuss this latest development is the Chief Medical Director of Heritage Men's Clinic and CEO Heritage Clinic, Dr. Rasheed Abassi. How are you doing, sir?
I'm fine. Good morning. Happy New Year.
Just before we went on, we're having a very beautiful conversation, but maybe we'll talk about it before we end the show. But yeah, thank you for joining us. It's always a pleasure to have you on the show. Reading this just gives me a lot of happiness that we are now prioritizing our own, because oftentimes we know how expensive it is. You want to travel abroad for treatment, you will pay ticket, you will get visa. But just knowing now that, people are now seeking more medical attention at home. But my own fear and worry is, are we now capable to do this? Do we have the equipment? Do we have the right hands?
Fantastic. And let's actually be realistic with the data. CBN is not being fair. They're not being truthful.
Okay.
So all Nigerians who travel for medical tourism, not all of us have access to CBN.
Okay.
A lot of this, you might have to go to your bureau to check private. You go to family and all that.
Yeah.
So yes, we give them credit that there has actually been some reduction. This reduction means less stress on the dollar. If there is less stress, then what are we doing with that savings? Because that will answer the bigger question.
Okay.
Nigerians are still dying. Our healthcare, currently now, maybe our medical institution, most of them are still on strike. And what are they on strike for? Better conditions, higher pay. These are the incentives that we enjoy in the diaspora.
Yeah.
So the grass can always be greener on this side. That's why, yes, we give them the kudos, whatever they're doing, let them continue to do it. But the reality is this difference and this reduction is just a drop in the bucket.
Yeah.
I'm a little bit surprised that you're saying it's a drop in the bucket.
Yeah.
It's 90, how many? 96%?
96, yes.
Yeah.
And look at the figures from
96%.
2-point-something billion dollars.
$2.38 million in January-June
to
0.09 million in 2025.
But you see, you're a medical practitioner, so you see things that I do not see.
Let them be transparent with the data. I will give you the example that I'm comparing it to.
Okay.
Washington, D.C. is a small city in U.S. Our population is less than 1 million, just over 700,000.
Okay.
We have 7 fantastic hospitals, none of which you see in Lagos, and our population here is excess of 20 million. So tell me about that drop. The number they're using only caters to the 0.01% of the affluent people. Majority of Lagosians, majority of Nigerians, were still considered medical and pharmaceutical deserts.
Yeah, but okay, let me just say something quickly. People often say that the people that have gone abroad and learnt, people like you that are well experienced, you've come back and you've set your own clinic. And not just you, a lot of people, I've had conversations with a guest on the show that, he learnt abroad, he's come back, set his clinic, and people are now coming to the clinic. So let's not forget that can also bring about the decline. Because right now, for people to travel to, you are in Atlanta, Georgia, now you have your clinic here, people can come to you, that removes the ticket money.
Absolutely, and that's what we want the government to encourage. That's what we're asking the government to incentivize. Because if you look at it, if you look at just the numbers, it dropped from 2-point-something million to less than 100,000. People will say it's a big deal. You and I can go to Lasukon, we can go to any hospital in Lagos now. It takes 3 to 5 days for you to be sane. And you still have to have money. So the bigger picture is still not changing. We give them credit for whatever it is, because now they're focusing on, there is less stress on that dollar. That less stress should translate into savings. And if the government really wants to tell us that healthcare is actually a priority, hey, let them put the money where their mouth is. Because we still don't have enough hospitals. We still don't have good pharmaceuticals. We're not producing any. We're the most populous black nation.
You see, I would like to ask you a question, but Ibrahim, do you have one? Maybe you should fire him first before me.
So as you said, the critics have actually argued, as you have said, that the decline actually signals the fact that some people are not able to even access the dollar, even though the exchange rate parity has been, harmonized. and then which is suggesting that patients are staying at home, not because local services are better, but because they cannot afford to go abroad. So how do you think, they are pricing out? Do you think this recent development is actually pricing out the poor to have access to best available care, even though the government, like for instance, as we said, in those states, is what is it called? Is also offering like 54,000 pregnant women, children, free healthcare services under the Abassi scheme, and then we have the one done in Oyo, the one in Ogun State, and even in Lagos State, different schemes to reach out to the poor and the needy. But exactly what is this broader impact on the poor themselves?
Fantastic. So the data that CBN is using, believe it or not, only on cardiovascular and cancer.
That's all?
That's all. The number one and number two reasons why Nigeria 2-3 years ago we're spending 2.3 billion on medical tourism is not for Abiyamo, it's not for women pregnancy. No, it's not.
No, but a lot of people also wanted to give birth abroad. Let's not forget that. Most people will tell you they want to give birth abroad.
So we're talking about people who really want to go outside.
Exactly.
Not everyone have access.
Yes. Your regular woman who is pregnant on the street is not worried about getting an American citizenship for her child. So only the very affluent who have that opportunity. The majority of Nigerians, what we're suffering from, the issue of cardiovascular, malaria still kills people in Lagos every 30 seconds. So that does not factor into CBN data. CBN data is only for you and I who may want to go there to say, let's go for a routine checkup. Or if I'm diagnosed with cancer, let me go where I can get chemotherapy. Yes, it may have dropped, but what are they translating that savings into? But to your question, some of the governors are doing a fantastic job in terms of creating better access to healthcare, whether for the low poor people. But which facilities do they have?
The facilities is the problem.
That is
but for me, this is quite scary, because I thought you would come here and speak about the fact that, we have Nigerian doctors that have come from America and, they're doing a fantastic job. But now listening to you, it's quite scary to see that. As a doctor, I will believe you because you understand what's happening in that terrain. So it means that even if we want to encourage medical tourism, we do not have the capacity. Is that what you're saying?
Absolutely. And we need to be able, the grass is not always greener in US, Canada. Look, step back and say, what are these governments doing that makes this guy just stay there? The truth of the matter, I can tell you for free. I belong to AMPA, American Nigerian Physician Association. Over 5,000 members. A lot of my senior colleagues want to come home. There are no incentives here. I mean, we can start. We open the Pandora's box. It's extremely difficult for you. You have to really know government officials to get certain basic things.
How did you get yours then?
I'm still struggling. And I've been coming to Lagos every 2 weeks now for the past 6 years.
Wow.
I'm still struggling. I paid a government in Lagos to buy land, officially advertised. I've paid. I'm here to get my land. And look, I have 20 employees. Can you imagine if I got the land and I've expanded, how many employees I can scale up to?
Okay, are we looking at these figures that the CBN is throwing around as trying to score a political point? And if that is the consideration, how fair is it to the poor Nigerian that will look at those figures and say, so now I have a chance? How fair is that? That's one side of the question. The other side of the question is, if you were given the responsibility to rejig the medical sector in Nigeria, what will you do to get the poor have access to medical care? And how is our Medicaid? Do we even think about it?
No. Excellent question, and I like the way we're going. So number one, we should not even be happy that we're spending a penny on medical tourism. How many times did you hear American officials coming to Nigeria for care? So it's a shame. It's not a number we should be celebrating. But where we are, it is what it is. Now the number is coming down.
In reality, do American citizens go elsewhere for medical care? Maybe like Cuba?
India. When it comes to kidney, a lot of people go to India actually.
So even though we're the US, we produce 17,000 doctors annually. The issue of Medicaid is being instituted into our legislation. So if I'm an American as I am, and I end up with kidney disease, there's no reason for me to go elsewhere. Number one, we have the best doctors in the world because we acclaim that and we have the technology to supply that. 85% of world medications that they consume in the whole world, we make them in the US. So where else are you going for? You still see some Americans who are on the low socioeconomic status and they say, look, okay, maybe I don't believe in this medical technology, I want to go for alternate care. They go to Mexico. Some of them go at their own expense, but the government will still give you the basics.
But let's not forget that our president also subsidized kidney dialysis. Let's not forget that as well.
No, we give them credit, but look, they can still do more.
For me, what worries me is access to medical services for the poor.
Yes.
So I'll ask you again, sir.
Yes.
If you were given the responsibility to take care of that, what would you do? Good. You understand the American side and you understand the Nigerian side. So how will you take advantage of it?
So it's a game of numbers. Number one, Nigeria, we don't have the data of how many doctors we're producing. So we need to change that. Data is the new goal. Let's have access to data to actually know the number of doctors we're producing. We have a lot of private medical universities in Nigeria that are not licensed to produce medical students. Let's grant them the license. The ones who are currently doing a good job, let's increase their number. It's a game of numbers. I just gave you, US produces 17,000 doctors a year. We're still short. In the US, we need 24,000 to maintain our status quo. Nigeria does not produce anywhere closer to that. And then Nigeria suffers from the jackpot syndrome. So that's why we need to incentivize our conditions home. Because if not, we're not going to win that battle. Talent goes wherever talent is appreciated.
Yes.
If we continue to produce great Nigerian doctors here, they're going to move out to pursue where they will be appreciated. So we need to reverse that. CBN should not be celebrating 2 million going down to less than. No, it's not a number we should even be proud of to start with. You go anywhere in the world, Nigerian doctors are top of the crib. Why can't we incentivize them to come home?
As we've done for you. But
I agree with that. I agree with that. We have great doctors. When we talk about Nigerians, when they want to do something, they do it excellently well. I mean, look at you doing fantastic well. Like when we talk about men's clinic, we definitely have to talk about you. But we also need to put that ideology in people that even when Nigeria does you well, stay. Because let me tell you what, oftentimes a lot of people have also lost hope in Nigeria. Because I don't want us to get to the point whereby we now start incentivizing these doctors, making sure they get everything that they need and then they fly out. So we also need people that care about their home, that care about Nigerians as well, the people that they'll be taking care of.
So Nigerian government has not incentivized me to come home. I came home on my own. Everything I've done is just personal investment. I'm facing some frustration, but I just believe so much in the country. And I took it personally. I said, look, every time I fly home, I meet Chinese, Indian, Lebanese, and these guys come home with one-way tickets. So they actually see something in my country that I'm not seeing. So like in my own language, what the hell am I saying over there for? I can do better here. The truth is, a lot of my colleagues, even more qualified, are ready to come home. The terrain here is not that friendly. I'm being honest with you. So that's why we need the government to do more.
What will be friendly for you? What will be friendly that you'll say that, okay, my people can come home now? What would you tell me?
So for example, I have 2 clinics in the state of Maryland. Both my clinics have been given 3 to 5 year tax break. I only have like 5 employees. In Lagos, I have 20 employees. Nobody cares. Even my local government chairman does not even know I exist. And you expect me to bring a neurosurgeon from the US?
When you say tax break, please break it down for me.
So if I'm entitled, let's say for my annual income, I'm supposed to pay 25,000. The fact that I have a clinic that employs 2 people, they tell me that I should pay only 12. That's an incentive for me to be in the field. For example, during COVID, my local government people were calling me, what do you need? Because they know I'm really dealing with the grassroots. The government, my government is not a doctor, but they know this is a medical doctor in an underserved neighborhood. We don't want him to close down. They're giving me things that I could have spent money on, giving me gloves, giving me... that is the involvement you need.
If you look at it too, one way or the other, if you look at the primary healthcare service, people have been saying that it's not really functional as it should, let alone talking about the tertiary healthcare service. But what about the attitude of those who have chosen to stay back home? They go to some of these hospitals, the way they treat you, the way they talk to you, the way they even beat you as a patient.
Pregnant women, actually,
you understand?
what they go through.
Exactly.
Oh, yeah.
People complain about these oftentimes. What can you say is the reason they do this? Is it frustration? Is it lack of proper training or lack of empathy that they should have? Even the only people that seem to behave, normal are the doctors.
No, fantastic. Even some doctors misbehave. And let the truth be told. Look, some of us abroad want to misbehave, but we know there is accountability. So when there is accountability, human beings will be human beings. But when there is accountability, then they straight line up. Here is where I want our government to use carrot and stick. If you come in, if you incentivize anybody, any physician now, you can now tell them what you expect of them. Right now, our doctors are overwhelmed. They're complaining about their working conditions and everything like that. And guess what? They're human. They show that frustration. I'm not condoning it.
Which is not supposed to be.
It's not supposed to be. You are in that medical profession. There is a calling. So you have to be able to keep your stuff. But hey, there's so much these guys can take. Again, if the government steps in and you give me carrot and stick, you think I don't want to close my clinic in Maryland on the weekend? The government told me you cannot do that. You are in an underserved community. We've incentivized you. So you must have a day in your week that you see underserved people. I agree. It's a trade-off. And that's why you see most diaspora doctors, it appears as if we're holier than thou. No, because there is accountability.
No, but when you talk about diaspora doctors, I know even in the UK, for instance, my younger sister gave birth, in the UK, and then she told us of her experience. The mother-in-law was there, and the nurse was finding it difficult to move closer to her, probably because she was black. I don't know. But the mother who works with the Air Force said, "Listen, I'm a nurse in the Air Force. If you don't do this, I'm going to have to report you." That's one. Another one is of a lady, even in the UK, a white lady who specialized as a nurse, specialized in killing infants. I don't know whether you saw the story. She was being tried and all of that. So it is not peculiar to Nigerian laws. So exactly, if this is happening in the UK, is it that people do not understand the dictates of their business?
Absolutely, and part of it is just improper training and that human greed. We're dealing with a case in the US of a cancer doctor who is diluting chemotherapy medication just for the fun of making more money. He's already making more than $10 million a year. That's human greed. So that's human fault. It's not peculiar to either Nigeria, UK, or anything. No, but the government is stepping up. There's a way they caught him. He's been it did not start this yesterday. He's been doing it for years. But there's a system in place that eventually they will catch you. Right? We're not even close to that yet here. So let's lay the foundation. Once we lay the foundation, then we'll be able to start taking, we can copy and paste. Some of these things, some of these regulations are already there. We don't need to invest into research. No, we collect the data.
Exactly. But, we are well aware that, I know that we can have better working conditions for our doctors. I have doctor friends. I know what they go through. So when we speak about this, I understand that it can be better for them. But also, I don't want us to be these people that we are always throwing blame on the government, that we do not look in within ourselves. Ibrahim just said something that made a lot of sense, because you go to these hospitals that even some of them that even still pay a little bit well, the way they treat people. We talk about frustration. People go to, even on this, my job, I'm frustrated, but I cannot be frustrated to bring anything out on TV. You understand? Because it's what I've learned, it's how I'm supposed to behave. So I think even the people that we are training as doctors, and this is not me saying that they are not going through harsh conditions, how do they behave? So we say government, even if government does something, you cannot change a bad person's heart to be a good person all of a sudden. Absolutely.
And so this, we're talking, they're already doctors, so then we have to look at, what about the selection process? How did we get to that point?
Yes.
Right? A few years ago when I was at Yale, they turned down people with perfect GPO. And I'm like, hey, that's a smart kid. They said, no, it's not only smart people we're looking for. We're looking for compassion. We're looking for empathy.
Okay.
True.
So who are the people selecting for medical school in our country? That's why we need data.
Not because there's need to fill the gap.
That is it.
Exactly.
Medical schools in Nigeria are looking for students to fill the quota. You see, that's the big difference with what you just described in Yale and what's happening in Nigeria. My worry has always been that the medical sector is so important. It's so important. That's right, yes. But we don't seem to give it the importance that it deserves. We don't do regulation. Tell me the danger. Let's educate us a little bit more about the danger of not regulating the medical sector in Nigeria the way it should be.
As a matter of fact, it has gotten so bad that Nigerian doctors do not believe in collaboration. Medicine should be collaborative. It's not adversarial. If you're a diaspora doctor and you pick a call from a Nigerian doctor and trying to talk to them about a patient in front of them, they automatically cut your head off because they think you're about to impose something to them. And the truth is, you are more experienced in terms of your clinical exposure and the people you've worked with, the technology you've seen. But again, it goes back into the system that, look, the government has to come in and show us how important healthcare is. Because the truth of the matter is, that is the strength of your economy. Is how healthy your population is that translates into everything else.
Exactly.
And so we need to find a way to balance that. The human factor will be there. Trust me, I just gave you an example in the US, a doctor trying to do that. You'll be like, why? With all the money that's human greed. But Nigeria or Africans, we've been a different fiber to start with.
And I like, as you mentioned, Africans, because I feel like another thing we need to look at is parents as well, forcing their children to be something that they don't want to. A lot of parents will force their children, you must read medicine. I know people that will tell me I'm a doctor because of my mother. That kind of person, how do you expect the person to, because he doesn't, somebody has shown you that maybe I want to be a lawyer, I want to be a mechanic, I want to be selling pepper, I want to do something very different. But then you are forcing the person to do something that the person doesn't want to. And that's why sometimes we see these people in positions, but they lack the empathy.
No, absolutely. And so again, we had a similar case like that in the US where they said tiger mom, Harvard or nothing. Even if whatever you make, if you don't get into Harvard, no, you are creating the bad precedents. We have to look at our selection process. When I applied to US medical school, 64,000 applied. They only accepted 16. And each and every one of us must write a plan. Why do you want to become a doctor?
Exactly.
And so someone will read and step. It's beyond your grades now. Someone is looking at you psychologically. Are you even emotionally ready for this task that you want to take up? That is why we need to invest into data to say, how are we even getting people into it?
That's right.
It's high time we get away from just filling the quota for quota's sake. Because that sector is vital.
Absolutely.
So vital.
Let's speak to some of the things that normally happen, especially for pregnant women, vis-a-vis the adoption of AI, because this is the era of AI technology, where a doctor will be in the UK, US, wherever, in Germany, and they will be performing operation on a patient in Nigeria, using the robots. I think one person has actually done it recently. How much have we adopted in Nigeria when it comes to technology in the medical sector? That's one. And what about profiteering in the medical sector, where someone who is going to labor, and then the first thing the doctor will think of is the CS, because they see that makes more money rather than the Hebrew woman birth. How do they describe that?
No. Honestly, you are bringing up important points, so I don't want us to undermine it, because that's financial incentive, and it's actually taking them away from standard of care.
So you agree?
No, it does.
But that's scary.
No,
it's really scary.
Again, we need a way to document. So if you and I are in the US and we decide we want to do a minor surgery, there's a database we can go and say, hey, Dr. Ibrahim, how many of this has he done? What is his failure rate? Has he been sanctioned? How many CMEs, how many continuous medical education has he gotten? You and I can look at that in the comfort of our home before we even pick up a phone to call his office to book an appointment. We don't have that in Nigeria. So our patients are at the mercy. In Nigeria, doctors are considered semi-god. So you go to LASUCOM, they'll say, hey, come here. They're shouting.
They are not even treating you well enough.
Absolutely.
Let's not forget, there's this woman, I don't know if you guys saw the story. She was having serious headache. She went to hospital. They told her they have to operate her brain. She had to travel out. I don't want to mention her name. She's quite popular. I don't know if you know what I'm talking about. She had to travel out, and they said operation where nothing is wrong. So this is something that is a barbaric act that we also need to make sure that
to open you up because of money.
Because of money. It's a barbaric act that we need to. This is something we also need to look into, because a lot of people are being operated for things that they don't have the sickness.
No, not only that. It's in Nigeria that one doctor will be your cardiologist, your pulmonologist, your surgeon. He wants to do everything together.
Give me your married counselor.
And that's where the problem is, because it's preventing other consultants to come in and say, hey, no, this is not the candidate for surgery. No, this is not this is not, because of the incentive of that money. And trust me, you and I cannot regulate them. It's the government that we need.
Exactly. And I've just written it down here that what we've discussed so far, because it shouldn't just be that we had a discussion. Let's see what we've achieved. You've talked about data, the need for data gathering, not only for the patients, but for the doctors themselves. What is their failure rate? What is this and that and that? So that is part of it. And then regulation, that is a government problem, right? Okay. And then collaboration. All right?
Absolutely. This day and age of technology, you can call anybody anywhere and say, look, I have a patient like this. Their first question is that patient stable? They will share their knowledge. No, see, there's no one man that knows everything. The technology is out there. They can share that. But we need to encourage that situation here. We don't. I did a show one time and I was talking about our people in Banana Island that they're not rich. I meant that to be provocative. Nigeria suffers from cardiovascular issues, the lack of stroke, heart attack. In Lagos, we don't have stroke center.
And now kidney even. And now a lot of people have a lot of
We're excess of 20-something million people. We don't have stroke center.
No stroke center.
No stroke center. So for you and I to invite technology, let's say Dr. Abassi start having a stroke now. You identify me, you call, you transfer me to a stroke center. In 45 minutes, I should be stabilized. Then you can now pick up your Rolodex and say, look, Dr. So, I need you. I have a guy here with a stroke, but he's stable. he or she will fly in. But if you cannot stabilize me, I'm a goner.
But let me say this thing quickly. If you were given the opportunity to make this better, okay, because you know, the whole world is watching you. We do not know who is watching. You know, what is that one thing that you will implement that you feel like if this particular thing is implemented, the rest will follow?
Number one, we need data.
So data
is number one. I also mentioned it. You see, Nigerian healthcare system is still old. We've not changed our curriculum in decades. I'm telling you that. In the US, we revamp curriculum like annually because we know that the world is very dynamic. Nigeria still operates on primary care, emergency room. That's a no-no. You know why? More people are ending up in your emergency room. By definition, more people will die. We're a country left with 55,000 doctors for over 200 million people. It's not sustainable. There is a leg missing. That is urgent care. We have a lot of experienced nurses. They're about to retire. They can become nurse practitioners. They can become physician assistants. They have the clinical experience. Make them go through clinical tests. They don't have to be nurses more. They become your mid-level providers. They can run your urgent care centers. Urgent care centers will remove the stress from your emergency room.
Amazing. We can go on and on with this, but thank you so much. You've been able to enlighten us on so many things, and I hope that, you know, what we discuss here is not just something that will pass. I know that our government is very particular about healthcare, so I'm sure that something will happen. There will be a change by the grace of God. Thank you so much, Dr. Rasheed Abassi. Thank you so much. Well, that was our conversation about healthcare, but still ahead on TVC Breakfast, with insecurity on the rise, Nigeria faces a defining moment to rebuild the security architecture. We will discuss the measures that can be put in place just after this break. Stay with us.